Welcome to the first course in the upcoming Triad curriculum addressing the use of nitrous oxide, oxygen, sedation, in dentistry. My name is Leanne Kiefer. I'm Director of Corporate Education and Professional Relations for Crosstex, a Cantel medical company, who's sponsoring this program. Today's course, Dental Phobia, Real or Misnomer, will provide an overview of the continuum of dental apprehension, fear, anxiety, and phobias. Fears and phobias are probably one of the most prevalent forms of mental anxiety disorders that affect people of all ages, gender, culture, and social status. Levels of dental apprehension have been estimated to affect 30 to 40 million Americans. While dentistry has made significant progress in creating a patient-friendly environment, yet despite these enhanced techniques, creating a calming environment filled with capable and competent clinicians, dental anxiety has stayed constant for the past 50 years. It is said to be ranked 4th among common fears and 9th among intense personal fears. Severe dental anxiety leading to avoidance of care is a common occurrence in the United States, unfortunately, where avoidance rates range between 6 and 20% of the population. A recent study at the University of Adelaide in Australia on dental fears notes that middle-aged patients, those between the ages of 40 and 64 years of age, are the most afraid of the dentist or the dental environment, while those golden senior citizens that are over 80 years of age have the lowest fear level. It's often they're edentulous as well. Women have also been noted to be more fearful than men, women at 21% and men at 12%. But consider this possibility that females may tend to be a bit more true with self-reporting. Another interesting statistic is that 12 tends to be the average age for a true dental fear to begin. When we talk about fear in general, human fear, personal fear, I went to sort of the people's resource for this one. I went to USA Today. And people are frightened by a lot of things, ranging from terror attacks to identity thefts and deaths within the family. All this is according to the 3rd annual Chapman University Survey of American Fears. This survey asked a little bit more than 1,500 people nationwide about their fears and concern across different categories, including things like crime, the government, natural disasters, personal fears, and technology. There was a shift between the 2016 survey data from the 2015, where most of the top fears were related to economic and Big Brother type issues. If we look at the overall fears in the 2016 report, we're seeing that governmental corruption is topping the list with 60% of the people reporting that, followed immediately by terrorist attacks at 41%. The fear of death or illness of a loved one rates high in the 30th percentile as well. When you look at this, people often fear what they cannot control. And when we look at personal fears and those top 10 that tend to get shifted around every year, we find that things that are out of control are at the top of the list, and we find a direct correlation to dental fears as well. So what about these everyday human fears? I'd like you to take a moment, close your eyes, and I would like you to put yourself into a place that makes you feel uncomfortable or uneasy. This whole conversation of dental fears may be difficult for those of us in dentistry because it's what we do day in and day out. But to be able to empathize with our patients, let's try and reconstruct that fear in an environment that you're not comfortable in. Can you imagine that feeling of being flushed or that your palms are beginning to sweat, or you're sensing that slight increase of your heart rate, or a little bit quicker respiration. Public speaking tends to be one of the top 3 phobias, and for me personally, it's not one of my anxiety triggers, which I'm fortunate. Fear of flying is often at the top of the list, and with all the media coverage of air disasters, it's understandable that many people fear being in a plane crash, and hence they have a fear of flying. But with over 100,000 commercial flights around the world every day, the chances of being struck by lightning, which is a totally separate phobia, are actually higher than dying in a plane crash. Mesophobia is also known as germophobia. People with this excessive fear of germs, this does not relate to being tidy or organized or cleanliness. These are people who believe the world in it of itself to be somewhat of a quote-unquote filthy place. As a result, they tend to always be washing themselves or cleaning something. They're known to spend major parts of their day doing these type of activities. Acrophobia, the fear of heights. Some people fear heights so badly that escalators at a shopping center or an airport can actually give them vertigo. For others, it's looking out over a cliff or a tall building, or this is actually a picture of my daughter skydiving, and she is acrophobic. Finally, claustrophobia, the fear of enclosed spaces. Sometimes actually the fear of flying is more closely linked to the fear of enclosed places than actually the plane crashing. People with claustrophobia fear, they say they feel like the walls are closing in on them, or that they cannot escape, that they're not in control. Some theories actually suggest that there are genetic links to specific phobias as a kind of survival mechanism, or a dormant survival mechanism. So now I really want to get into the issue of this continuum of dental apprehension through the stages of fear, anxiety, and phobia. Fear is a distressing emotional response or an emotional reaction that is initiated by a real or imagined immediate and present danger or a specific threat to one's safety. Fear is objective. It is not subjective. It's objective because it's directly linked to a specific trigger, a known danger. You can often ask a patient who is experiencing a dental fear, what is it about the situation or the environment that's causing them to be fearful? So with fear, the source is easily identifiable, and normally what happens as far as the protective mechanism, this is the flight or fight response that occurs. Again, some people are very reluctant to admit fear, and they will act out in other ways that can also help to identify that a dental fear is underlying an issue. While anxiety is actually synonymous with fear, anxiety is an emotional state. Remember, fear was an emotional reaction. Anxiety is an emotional state which precedes the actual encounter. It happens before you actually encounter the threatening stimuli. The source of these threats is often unclear, ambiguous, or, as I said, not immediately present. These patients may have a sense of impending doom. And unlike fear, when a patient is questioned about the cause for their anxiety, the source is not easily identifiable, yet those emotional reactions, those emotional responses that are observable are almost the same in both situations of fear and anxiety. This is usually associated with, like we said, dangerous or unpredictable situations. And some of the physical symptoms that a patient might exhibit would be skeletal muscle tension, GI disturbances. They may talk about sleep disruption. They were not able to sleep the night before they came to their appointment. You may pick up hypertension when you're taking, even if it triggered hypertension during the appointment. Myalgia, neuralgia. They may also express tension headaches. And anxiety is often closely linked to painful stimuli and thereby increased pain perception. So these patients who are at the level of anxiety may experience more pain or a higher level of pain that may last longer, and they may also exaggerate the memory of their pain. I will review or overview phobias, but we're not going to discuss them in great detail simply because of the time available to us and the rigors required for an appropriate diagnosis of a true phobia. A dental phobia is a more serious condition that leaves people panic-stricken, and they're actually terrified. It's an irrational level of a fear reaction. It's excessive, it's persistent. They talk about these type of reactions lasting for 6 months or longer, so it's not it happens one time and it doesn't happen again. People with dental phobias have an awareness. They know that that fear is totally irrational, but they're unable to do anything much to change it. These phobias, in fact, are persistent, unrealistic, and it is an intense fear of a specific stimulus which may lead up to complete avoidance of whatever that perceived danger is. There's very little that the patient can do to comfort themselves or that we can do to comfort them, so there may be other behavioral or medication interventions that are required. An overwhelming and irrational fear of dentistry associated with devastating feelings of hypertension, terror, trepidation, and unease is termed odontophobia. And this has actually been diagnosed under the specific phobias according to the Diagnostic and Statistical Manual of Mental Disorders. So the vast majority of our patients will be somewhere between the apprehensive, fear, and anxiety portions of the continuum. It's estimated about 10% of our patients will be listed within the true phobia level. So what are the responses to fear and anxiety that we would look for in our patient? And both dental anxiety and fear evoke physical, cognitive, emotional, and behavioral responses that we need to be aware of. Let's review some of those in a little bit more detail. The physiological reaction to fear stimuli are characterized by the symptoms of the flight-fight response from the adrenal glands of our kidneys. And the response is things like the typical quickened heart rate, nausea, sweating, muscular tension, and an increased respiratory rate that's getting our body ready to pounce, ready to respond to a perceived threat or to a real threat. Additionally, you might notice if you follow up with patients following an appointment, these are the patients that are going to report feeling exhausted after a dental appointment, whether it's something as straightforward as a scaling root planing or a very simple operative treatment. They will report feeling exhausted. When we looked at some of the other responses to fear and anxiety, Cohen reported that dental anxiety affects patient lives in various ways. The cognitive issues may impact and cause an array of negative thoughts, beliefs, and fears that can be perpetuated. The behavioral impact that we might observe would not only include avoidance of even not only just dental appointments, but how they perceive their own oral care, how they perceive some of their eating habits, and that this may be a self-medication addiction type of an issue that may be addressed. Finally, we may also see these patients react in an overtly emotional level, that crying may be apparent, or they may behave in aggressive ways verbally or in refusing care. I want to take time to talk about this vicious cycle, this dental cycle of fear or fear cycle. Basically, it's self-perpetuating. When we talk about fearful dental patients, they experience, remember we said, that sense of dread to the point that they may avoid dental care. They can do things like also passive-aggressive, showing up late for appointments, canceling at the last minute. These kind of activities also then, when they avoid dental care, it actually places them into an underserved sort of special needs population due to the avoidance of treatment. These delayed visits or canceled visits result in poor oral health, obviously more decayed or missing teeth, and more progressive periodontal disease. They tend to present to the dental office only for acute, symptom-driven treatment. Most likely this is due possibly to a toothache, and at that point it often requires us to provide a more complicated treatment, somewhat more traumatic to the patient, which then further exacerbates and it reinforces their fear with a vicious cycle which feeds back on itself if these patients are not managed appropriately. So we have to make sure that we know that when oral health is compromised, that overall health and the quality of life may also be diminished. And so we need to find the best ways for each individual patient to break this cycle of dental fear. When we talk about the pathways of dental fear, how we tend to come by these fears and display them, we need to understand factors that are underlying the etiology or the cause of the fear or anxiety, because that may actually help us to determine the interventions that we can use to reduce these dental avoidance behaviors, to reduce the fear and anxiety our patients are feeling, so they will be more cooperative. And there are many, many theories on the causes of fear. And I'm just going to sort of do an overview. And let's start with sort of the classical conditioning. And I want you to think about the Pavlov's dog experiment. And this is the type of reaction that occurs as a result of an actual negative experience with a dental procedure. And as that negative experience occurred, that patient learned a conditioned response that he now or she now associates between the dental office and the way that they're feeling. And so their fear or anxiety becomes conditioned when they are back into that stimulus. And therefore, future dental visits are able to evoke the same level of a conditioned fear response. When we talk about informational learning, we've all heard people telling horror stories when we go to parties. Everybody wants to share the difficult events that they've experienced when they were at the dental office or when people have gone through labor and delivery. Sometimes we talk about these as being verbal threat transmissions. Patients learn about this dangerousness of the situation from other people without observing it directly. So this is an indirect learned response, where the classical conditioning is very much a learned response. And the verbal threat pathway, the best thing we can do to that is, it's when an authority figure threatens an individual about a painful experience. And with odontophobia, those pathways differ in that verbal threat pathway occurs when the visit to the dentist is actually used as a form of punishment, as a form of threat. And very, very unfortunate. We also look at vicarious learning. Sometimes vicarious learning has sometimes been referred to as also the parental pathway. And this is when a patient sees the fearful experience or expressions of others. For an example, when a child observes a fearful response of a patient, either during a dental appointment or leading up to appointment, may learn indirectly about this potential situation. It was interesting that there was a study that was published in 2010 that said research has demonstrated that dental fear of a child who is 8 years or younger is significantly related to the dental fear of the parent. Last but not least, the one I did not put up here is actually genetic vulnerability. And this one's a little bit tricky because some people with actual phobias, we're not talking anxiety or fear, we're now at the phobia level, they've actually inherited genetic vulnerability factors that predispose them to anxiety in either general or certain phobic situations. In the Roy Burns study, it indicated that people with specifically dental anxiety or odontophobia are 20% more likely to have other anxiety, fears, comorbidity, or mood disorders. And while people with true odontophobia do not directly inherit the phobia itself, genetic vulnerability forces may interact with other elements that can exacerbate or bring on the particular phobia. Let's talk about identification of patients with dental fear. And the studies have shown us that essentially there are 4 different types of patients that present in our practice with dental fears. The first one are going to be individuals who are fearful of specific stimuli. And we identify them because most common of these things are going to be things like injections, or the sight, sound, smell of the office, the sound of the drill, the pain associated with certain procedures. And this type of fear, the treatment for this means gradually exposing the patients to those stimuli that allows them to sort of become desensitized, so that it desensitizes them away from that specific dental fear. And there's specific things we'll talk about toward the end about how that can be done. We also have individuals who are fearful of a medical catastrophe. They're afraid that something's going to happen during treatment that's going to cause a medical emergency, like a heart attack. And often, these are the kind of patients who are going to come in and they're going to tell us that they are allergic to anesthetic, or they have a reaction to local anesthetic. They may also report that they're ones when they say they can't breathe, they feel like they're going to choke, especially when we put a rubber dam in place. These are patients who often ask us, they just sort of want to grin and bear it. They're going to ask us not to use anesthetic during these procedures. In addressing this particular type of fear, it's important that we provide education. We need to take a full medical history, provide education, and then do gradual exposure of the different procedures with these patients. These are not the patients that are going to respond well to sort of vague, reassuring comments like, well, anesthetic allergies, real allergies, are very rare. What we want to do with them is possibly use relaxation skills to help slow their breathing and make them more comfortable. We then have patients with generalized dental anxiety, and they have significant anxiety just in the anticipation of dental treatment. They're usually not able to say one thing all over the other. They'll say things like, it's all terrible, it's all difficult. These are the ones that are usually going to report other fears to you, or you'll find out that they may also have fears of heights or fears of claustrophobia. As I said before, these are the patients who are going to tell you that they didn't sleep well the night before, or that they're feeling just really too exhausted for care today. And the bottom line for these patients is simply worry. They worry about the procedure itself. They also worry about their own behavior, whether they're going to be able to contain their own anxiety and fear level. And so these patients respond very well to honest reassurance before, during, and after the procedure to help alleviate their worry. Last but not least, we have the challenge of the distrustful. They distrust the dentist or the dental staff. And these are our challenge patients that they come across as argumentative, or they're suspicious of the treatments that we're recommending. Where our previous patient, worry was the issue, this patient, it's about being in control. So what we want to do with participants in this category, it's give them information and also engage them by asking their permission to move ahead with care. Engage them so that they begin to trust you. These are the patients that may do really well either wanting to watch in a mirror, though not all of them do. These patients may prefer to have their dental treatment plan in writing as opposed to being verbal. And it could also be that these are the ones that are going to want to ask for a second opinion. So when we identify the fears of our patients, these are some of the common fears being put into very specific explanations. So what are patients actually afraid of? The studies say they're most afraid of three things in the dental office: the fear of loss of control, the fear of embarrassment, or the fear of pain. And pain, or the thought of pain or of any kind, is going to elicit at least some level of fear in all of us. And unfortunately, dentistry has long been associated with pain. But remember, dental science and our techniques are better than they've ever been, and we have the opportunity to educate our patients about the improvements that we have. And obviously, one thing is for certain: any type of early detection and treatment is always better for everyone. The fear of the unknown. And that's just, it's not only the unknown, but it's what the patient doesn't understand. And so we want to make sure when we're explaining things to patients that we're using terms that are patient-friendly and that we're taking the time to ask if they need clarification. The unknown can also be fear of a faulty diagnosis or fear of an incompetent clinician. On the opposite end of the spectrum, they have fear of hearing the truth. They have fear about hearing a bad report about their oral condition. We talked about patients being in control and feeling that loss of control. I read an article recently that said when we put patients into a dental chair and we recline into the supine position, that often it makes our patients feel like a turtle that's been flipped on its back. They feel like there's been a relinquishment of power in their control, and this is going to kick off issues of anxiety, possibly confrontation, and even avoidance. We can sort of balance this shift of power by allowing our patients to say that maybe we're going to give them a signal that if they need to stop treatment for a minute, or if something is uncomfortable, or they need to ask us a question. We could do something like simply asking them to raise their hand. With patients who have a fear about the gag reflex or of choking, we may tell them that if they raise the index finger on the one hand, that the assistant would then be triggered to know that they feel that they would need use of high volume evacuation, or to give them control of using the saliva ejector would also be another way to help to balance that, that sense of power. Some people are also, they lack self-confidence, they're ashamed of how their teeth look, and they're afraid that they're going to be judged, chastised, or ridiculed. And so we need to create a safe space for them. For you and I, some of the odors in the dental office don't even faze us anymore. We can't even smell it. However, for others, it's very pungent, and it has that definitive dental office smell. And so we might want to consider doing something like an aromatherapy in the treatment room to help the patients feel more comfortable. Allowing them to see equipment, and if appropriate with infection control, allowing them to touch can sometimes reduce the level of anxiety. Our patients are also, our patients can also feel claustrophobic, and they can feel claustrophobic when they sit in a chair and then they feel closed in by the clinicians on either both sides, or the close proximity that we tend to need to work 14 to 16 inches from the patient's face. They feel that fear of being unable to escape. Sometimes also, believe it or not, it's triggered by use of face masks. I am not recommending that we don't use them, but that can be part. So it's important to maybe explain to the patient why we're using face masks and how it protects them as well as protects us. The fact of rubber dams can also prevent any type of materials from going down to the throat. It's going to prevent water from being back in the back of their throat, so that's going to make them more comfortable. There's also the issue of not just being hovered by clinicians and the small equipment, but our treatment rooms tend to be smaller. When our patients are in that dental chair and they're doing the turtle on the back, their mouths open and they're unable to see or know what's happening. And so they can feel overwhelmed and fearful. And so it was interesting, just this last week, I saw the average size for personal space of Americans is about 3 feet apart. Yet in dentistry, we invade someone into one of the most vulnerable and personal spaces of their oral cavity, and we're about 14 inches nose to nose for a period of time, and thereby obliterating any of their personal space. Some of our equipment can be threatening. It looks threatening, it's loud, it's sharp, it's terrifying, and as I said, allowing the patient to hold and inspect tend to help. For every little facet of fear or anxiety, there is a mechanism or two that we can use very simply to slow down that flow of fearful thoughts and help to keep our patients on track, make the appointments easier, and this helps to dismiss patient fear, and it builds long-term trust. I guess I forgot to flip my slides because there's your last one. Obviously, cost can also be an issue, but in the studies that I was reading, when it came to cost versus true fear, fear actually overwhelms cost. Let's go a little bit into pain, since fear of pain was one of those specific pathways that we had referenced. And pain is a very subjective experience. And the threshold for which we experience that level of discomfort is unique to each individual. Our mind and body work together. We can't separate them. Likewise, fear and pain are so interrelated that they're very often hard to separate, to distinguish between the two. And both fear and pain, or fear and anxiety, anxiety and pain, have physiological and emotional components. Remember that pain is a feeling that's triggered by the nervous system, which can be felt or determined as a prick, a tingle, a sting, a burn, or an ache. A pain can either be sharp or dull, and it may come and go, or it can be constant. And as the level of pain increases, the anxiety is heightened. And as the anxiety increases, the pain becomes enhanced, and therefore becomes less tolerable for the patient. So by addressing the anxiety before the pain stimulus is presented, we can help, hopefully, to lessen the continuum of anxiety and pain. Age, gender, race, ethnicity, and psychosocial factors all influence the way people experience pain. Pain itself and the fear of pain can cause one to avoid certain activities. The BARS study showed that 66% of the people surveyed attributed their anxiety of going to the dentist due to the fear of anticipated pain. Again, remember, fear is anticipated, anxiety is real time. So when fear and pain are an issue, both must ultimately be managed. This is the fear of needles, fear of injections, and it is considered a phobia since it's very specific. It is defined as an irrational fear. It's estimated that at least 10% of American adults have a fear of needles, but it's likely that the actual number is larger, as most of the severe cases of needle phobia are never documented due to the tendency that the person will avoid treatment. It's been reported that 1 in 4 adults have a significant fear of dental injections, which may deter them from seeking help. The possible signs and symptoms of needle phobia, I don't think it's that hard to discern, but it may be something like even the sight of blood, the sight of a needle. It may cause increased heart rate, a drop in blood pressure, nausea, dizziness, even up to fainting. People who are needle phobic, their responses to injections may cause the sufferers to avoid things like vaccinations, blood tests, and in more severe cases, all medical care. But we need to remember that needles are typically worth the discomfort associated with them. Things like delivering local anesthetic or vaccinations, conducting or delivering blood donations, helping to investigate a potential illness. And education can be one of the best approaches to ease a patient's dental anesthesia, along with the appropriate use of topical anesthesia, a slow injection technique, and possibly the use of an anxiolytic agent such as nitrous oxide oxygen sedation, if only during the time of before the injection and after the injection, because once the injection's over, perhaps you're going to have a very comfortable patient. So we need to explain and offer other types of anesthesia and sedation in conjunction with local anesthesia to help our patients feel more comfortable and accepting of dental care. We've been talking a lot about the patient because the patient is our most important responsibility, but I think it's also important for us to think about what is the impact of a patient's fear or anxiety or phobia on the dental team. And dental clinicians agree that anxious patients can be very difficult to manage and to treat. And many of us experience feelings of frustration or inadequacy, that we can't help them, and it leads to more increased stress when treating these anxious patients. We know from studies that the anxious patient is more likely to be late and 3 times more likely not to show up for their appointment at all. In addition to this, because of the different interventions that we may want to offer our patient, it may take up to 20% more additional appointment time to treat an anxious patient. Being able to appropriately identify an anxious or fearful dental patient is our first step in positive intervention. And so the use of subjective and objective evaluation can be great tools to enhance the identification of our dentally fearful, anxious patients. You can do something as initiating the discussion of dental apprehension, like on the health history, or you could just ask a patient on a scale of 1 to 10, how fearful or how anxious, are they feeling. However, we're very fortunate that there's a multitude of standardized scales that are available to us to assess not only sort of that subjective, but it can assess the emotional, the behavioral, the physiological, and the cognitive status of the patient. I'm going to talk about 3 different scales. I'll reference them that are currently are being used frequently in dentistry. And the Modified Dental Anxiety Scale, it's often referred to by the acronym MDAS. Because dental apprehensions are real and subjective, they cannot always be measured objectively. However, these questionnaires can help to assess anxiety and fear. And sometimes, believe it or not, just asking the patients to write out or address the fear, put it on paper, is almost cathartic for them. And it may be that push that they need to be able to discuss it with you or to better understand his or her own fears. The MDAS has a 5-question survey. The questions being, if you went to your dentist for treatment tomorrow, how would you feel? and the patient is asked to rate it between the scale of not anxious all the way up to extremely anxious. They'll follow that same scale with the following questions of, if you were sitting in the waiting room awaiting treatment, how would you feel? If you were about to have a tooth drilled, how would you feel? If you were about to have your teeth scaled and polished, how would you feel? And if you were about to have a local anesthetic injection in your gum above your upper back tooth, how would you feel? This 5-section survey, each item from the non-anxious being a scale of 1 to a high of extremely anxious being a scale of 5, the sum of the patient's responses would then be added together. So the total score on the MDAS would range from 5 to 25. Now, what does that mean? A total score of 19 or greater indicates a high dentally anxious patient, or even possibly a dental phobic, and that might be time for a referral. But at least what you're doing is you're able to somewhat classify. Why do we like this? It's quick to complete. The MDAS is widely used in a lot of survey, experimental, and clinical studies. It has great evidence in its validity. It's also great that the answering scheme for each question, those 5 different options, are the same for each one, so that you can sort of do a comparison between the answers between the questions. This functions very well as a screening tool. It is not a definitive diagnostic. It has also been reported that this particular scale is very acceptable to patients. It does not raise their anxiety level, so they're very comfortable completing it before they come in for an appointment. Another nice feature is that it is available in numerous other translations and languages. The next one that I want to discuss is a little bit more detailed, and this is the Mount Sinai Dental Fear Inventory. This one consists of 14 different situations, very common in the dental setting. And the inventory includes many common sensations for the patient as well. It allows the individuals to also, you see at the bottom, you see other, that they could actually add their own category of a fear point if it's not already included. Each of the items is assigned a value of 0 to 100. And a 0 would be if the patient were saying they're so comfortable, they're in complete relaxation mode to the point they might even fall asleep. Where a 100 is the point level when fear is at its absolute greatest, to the extent the patient may feel like they're going to faint, they're going to become ill, or that they're unable to complete treatment. Obviously, the higher the cumulative point value, the sum, the higher the level of dental apprehension experienced by the patients. And while these answers provided by the patients are subjective, they do provide us with a visual initial baseline to express the level of apprehension that our patients feel. The SDFQ. The SDFQ, as I said, there's many different instruments that are there to measure fear. And the best known and the most frequently used would be the Dental Anxiety Scale, or the DAS, and the Dental Fear Survey, or the DFS. Both of those have been used in adults as well as in adolescents. However, for clinical practical purposes and timing, those two, the DAS and the DFS, are rather long questionnaires, and their interpretation takes additional time to review. For us, we need to know about the patient's possible dental fear before the first procedure, before we pick up that first mirror and explore, because we have to be able to choose the best way to deal with the patient's dental needs. Hence, the short dental fear question. You'll note there's only one question. The last time you visited the dentist, how did it go? There seems to be, with this question, there seems to be a correlation with the previously 2 validated dental instruments, the DAS and the DFS, with this particular survey. And they actually said correlation among the 3 dental fear measurements were relatively high and similar. This SDFQ might be a useful instrument for the clinical measurement. It's compact, it's easy to answer, easy to interpret, and thus convenient to use in a busy clinical setting. It also indicates patients' potential for avoiding fear. If you see, they say treatment was difficult, treatment didn't succeed, or I totally missed my appointment. So this could address the issue of avoiding behaviors. You know, if we keep our eyes and ears open, it's not just what happens once our patients are in our treatment care areas. With the help of the rest of our dental team, sometimes we can observe some of these issues early on while the patient is still in the reception room by observing patient behavior and possible anxiety. We shouldn't be using these things as a measure of diagnosing dental fear or anxiety, but simply a collaborative bit of information to add to any other objective measurement tool that we use. Restlessness may be seen by patients fidgeting with their hands, or they're pacing and walking around the reception room. They change positions frequently, or they're always checking their cell phone. We may see a bit of hyperactivity with them sitting on the very edge of the chair, and they're going to be leaning forward position as opposed to leaning back. They may be rapidly flipping through a magazine and not reading. Or you may see some repetitive movement of their limbs. If you think about restless leg syndrome, this would be an indication of hyperactivity. Also, we look at some of those things that are very simple. Things like, are they sweating? The palms of their hands, their forehead, their upper lip. When we see them breathing, are they sighing deeply as they're sitting out in the reception area? Sometimes these patients may exhibit irritability as a result of delays in being called back. We may see this irritability by them coming and asking how much longer. They may talk loudly while they're in the reception room. And last but not least, we have those difficult patients that are fearful, that have anxiety, that they have emotional outbursts in front of our other patients. They may be making negative comments about the dentist, the staff, the appointment, or dentistry in general. And if we can whisk these patients away into a consultation room or somehow put them into a different environment, it can be best not only for them, but other patients sharing the same space. Once we have them into our clinical area, you may observe some of the same similar anxious behaviors that were in the reception room, but they may develop some additional responses now that they're actually in the treatment area. Things like, instead of being fidgety, they may become almost silent and stone still. You may note a very stiff posture, and they may be physically closed in their nonverbals, such as they have their arms or their legs crossed. They may have a very firm set to their jaw. You may also notice like a very strong startle response as the back of the chair is lowered or as there's any movement within the treatment room. These are the patients who may hold things tightly. If you have a woman, she may be clutching her purse while it's sitting on her lap. Or you may see that dreaded white knuckle response as they're grasping the armrests. It's interesting with some of these things, a very simple technique that we could do is to say to the patient, you know, instead of saying uncross your arms or legs, it sounds so much nicer to say you might feel a little bit more comfortable if you would uncross your ankles. And it's a suggestion, but they're still in control of the action. So using the word might is a great word. These patients also tend to avoid eye contact with us. They may be frequently clearing their throat. While some may get quiet, others may speak, and they may speak a lot faster. They may get a bit tongue-tied, stumble over their words, and they may be asking a lot of questions that almost is sort of a delay technique. Take visual note of the depth and speed of their respiration. People at rest are going to breathe about 16 times per minute. You can also very easily visually note the pulsation on the carotid and the temporal arteries, and also look for any type of flushing or blushing or hives that may be starting about the face, the neck, and the arms. There are a number of very detailed approaches that we could take, from either a psychotherapeutic avenue, which addresses patient behavior, or even learning through cognitive training. We also, for some patients, may want to offer adding some of the pharmacological or anxiolytic type drugs, which could be, as we mentioned earlier, something as simple as and safe as nitrous oxide oxygen sedation. Some patients may require an oral sedative, and there's also the possibility of general anesthesia with an approved certification in a clinical setting. And in one of our future programs, Dr. Mathers will in fact be addressing those issues specifically. So what's the simple word? The simple word is to be friendly and genuine with our patients, to be calming and reassuring with our words, with the way that we move, with the way that we walk. We want to pay attention not only with our eyes, but also with our ears, and making sure that when we're listening to our patients, we are using empathetic listening, and we might be parroting back to them what we heard them say, asking for clarification. And while we know all the big words of dentistry, we want to make sure that we're using patient-appropriate, not condescending, but patient-appropriate words that will help to explain what's going to be happening. Encouraging the patients to ask questions at the appropriate time. Obviously, we can't have it interrupting the procedure. And the concept of using tell, show, do, we've done in dentistry for years. We've done it with children, and it works very well. However, I found an interesting article excuse me, that was talking about a variation with adults called explain, ask, show, do. And so by explaining what the situation is and then asking the patient, may I go ahead and show you what this would look like? And at that point, may I go ahead and start the procedure? This is gaining their mutual cooperation. So they're giving you permission to proceed to the show and do phase. And this helps to balance their fears, and it also helps the patient both physically and emotionally. So again, explain, ask, show, do. We create the right ambience in our practice from the time they come into the building, how they're greeted by our business office or reception manager. It may be an auditory calming effect from the music, a visual distraction from something like a fish tank, or use of videos while in the treatment area. Again, having a non-hurried and caring attitude, and possibly offering various types of aromatherapy. And it's been noted that lavender has been one of the most effective essential oils that's used within a dental practice. There are also other type of behavioral techniques that can be offered and learned, guided visual imagery, repetitive breathing techniques that help to slow the nervous response system. There's also different type of tense and relaxation for various points of the body that can help to put that patient into more of a relaxed and physical state. While that ends our overview of fear, anxiety, and phobias, I'm pleased to remind you that our key opinion leader and respected colleague, Dr. Frank Mathers, who is an anesthesiologist, is going to be presenting the next lecture in this nitrous oxide curriculum. And he will be presenting the scientific and clinical application of nitrous oxide oxygen sedation. He'll be presenting on Wednesday, August the 2nd, beginning at 4 p.m. Eastern Time. If there are any particular questions at this point in time, I'm happy to address them. There was a question about someone said that she had always been taught not to bring up fear with the patient because it would just make them nervous. And I think it has to do with how we address the situation. And again, sometimes allowing them to verbalize it, takes the fear out of hiding, and it helps the patient, that cathartic feel that they're going to be able to discuss it. So there's a lot of evidence that indicates just bringing up fear is not going to excite fear. I've been asked about the repetitive breathing technique. There are a number of different ones, and I would not advocate for any particular one. However, there is a cleansing breath that's taken, and then to have the patient inhale very slowly through the nose for a period of 7 seconds very evenly, or 4, I'm sorry. Have them inhale for 7 seconds, then you want them to actually hold the breath, and you want them to do more of a diaphragmatic inhalation, not an upper chest breathing, but a diaphragmatic breathing. Have them hold that breath for a count of 4, but before they exhale it, have them put the tip of the tongue on the palate just behind the maxillary central incisors, and then just have them casually release the breath through open teeth with the tongue at the top for a period of 8 seconds. You can have them repeat that 7-4-8 pattern 3 different times, and that's one of the patterns that has been very successful in repetitive breathing. Would I be willing to share a PDF of our PowerPoint? What I can tell you is that we are partners with Viva Learning, and this webinar is going to continue to be available to you on demand, that you're going to be able to go back in and review. The information on the CE credits will come at the end, and that will come from Viva Learning. That was another question. And I think that answers all of the questions that I can see on our question. Oh, I'm sorry, one more. Would a lavender scented candle work? And this person is referring to aromatherapy. A lavender scented candle work, or should it be actual essential oil? I think that's something that you would have to look into for what your office is comfortable in using, because some of the issues with having candles within a dental practice, just a little bit of the dangerous issue, that obviously using a diffuser, or like a reed diffuser, or using an electronic diffuser, you may also get a little bit more permeation by using the oil as opposed to using the lavender scented candle. So essential oil is going to be much more of a pure scent. There was one other question that I saw pop that I will take. Hang on. And it has to do, somebody asked about with children, especially with needles, is it better to show them or to hide it? And I don't think showing a child, this is my personal opinion, and every professional is going to have to use their own clinical judgment to decide what your injection technique is going to look like. But for me, I would rather spend the time trying to work with the child, maybe through a picture book, explaining what sensations they may feel, and practicing things like placing the topical anesthetic and letting them allow to feel that. So I think it's a matter of taking steps with a child rather than showing equipment in this case. So with that, I thank you all very much for taking time at the beginning of the week and participating in this Crosstech sponsored event. I do hope and highly recommend that you come back to join us when Dr. Mathers is here on the 2nd, and then we will actually be finishing the final course. I believe it's on the 23rd of August, again beginning at 4 p.m. Eastern Time, and Dr. Mathers and I will be presenting that program collaboratively. At that point, we're going to be addressing safety issues, not only for the patient, but also for occupational safety, and we will be addressing specific practice management issues. So if there's something that comes up as a question between now and the 2nd and the 3rd or 23rd, you'll have another opportunity to ask us. So I thank you again and wish you good night.